Dr. Ayman, for inviting me to give my talk in this conference. Actually, I'm going to discuss chronic pain. I was asked that they want about chronic pain assessment, because chronic pain was always thought difficult to assess. But recently, actually, there's acute pain problems causing persistent postoperative pain, which is causing more problems now than chronic pain. And they had recently introduced consensus for chronic pain. So anyway, the first step in chronic pain is to know what is acute pain and when does it change to chronic pain. Acute pain states can be brief and lasting moments or hours, or they can be persistent, lasting weeks until the disease or injury heals. But chronic pain was defined as persistent pain, which can be either continuous or recurrent, but it is of a sufficient duration and intensity to adversely affect the patient's well-being. Now, when the patient comes first, if the patient is previously evaluated, to differentiate between, you have to evaluate and assess him to differentiate between untreated acute pain or an ongoing chronic pain. If he has pain that persisted for 6 weeks or more or longer, then it is anticipated, done the anticipated healing time. A thorough evaluation for the cause of the pain is necessary. Why? Because if he's going to reach a chronic pain syndrome, and in this situation, it is quite serious because it's a constellation of behaviors that relates to persistent pain and disrupts his whole life. Of course, we all know that now it is agreed that effective treatment of any pain is a basic human right, and this was introduced by the WHO since 2004. And since then, the war started on pain. And all the literature and the magazines introduced were talking about pain, that it is when is the right time to, what's this? Is it the right and wrong way to treat pain, whether it's in the body or whether it's in the head? Why headaches? How can we prevent them? Why pain hurts? And how we can unlock the mystery of pain. And this was a new war on pain then. But still, pain remains the oldest and medical problem and the most feared, and the universal physical affliction of mankind. Yet, it is the least understood and the least managed. We all know definitions of pain, but this is actually a definition which I like, especially in chronic pain. It says that pain is a subjective experience. It is highly personal and subjective. It is whatever your patient says it is, existing whenever he or she says it does. So self-report of pain is considered the most reliable indicator of pain. So you have to always believe your patient. These are the chronic pain disorders. Of course, we've seen neuropathic pain, we've seen nociceptive pain, but remember that we've got also mixed pain. I won't go into details. You've heard a lot about the neuropathic, the nociceptive, but there are the mixed pain. So how do we assess pain? In order to assess the pain, we should start first with a pain questionnaire. And then this is followed by general and special medical examination. History is very important. you have a special pain history, you have a general medical history, a drug history, and a social environment history. Of course, when the patient comes, you expect him to know how to read or write, but if not, one of his close relatives or a near person is required to help him with that. The first critical steps in assessment recommendations is that all patients should have an adequate pain assessment, because it's only through that you're going to carry on and treat your patient. The general history and physical examination should be completed in assessing the chronic pain. The plan is to use our most important step. First step is the self-reporting, because this will facilitate regular reassessment and follow-up according to the criteria developed by the individual organization, because every organization has its own pain guidelines, and we'll see how. This is followed by the history examination, and there, in addition to that, certain areas deserve specific attention. But remember that the history of chronic pain in the patient may be very revealing and very helpful. Diagnostic test. Do we need diagnostic tests to prove pain? No. Diagnostic tests are not for chronic pain, but they are useful in patients with chronic pain to direct the treatment and referral. Like, for example, X-rays, MCTs, MRIs, and so on. What we use is functional. Function assessment is very important to identify specific impairments or disability. And the pain assessment tool, self-report, this was the most reliable indicator of pain by the National Institute of Health. So, to assess chronic pain, it should be appropriate for the person regardless of his age, race, or creed, or his social background. It should include a multidimensional scale, since chronic pain affects the entire person, his entire being. Address the location, of course, of pain and its characteristics. Use it early in the process of the patient evaluation. What are multidimensional assessment tools? There are multiple multidimensional assessment tools, but I thought the one which is very important and we should all know is the brief pain inventory. And this is a written scale. The other scales, such as the chronic pain grade, which is verbal, the neuropathic pain scale, it's verbal, but there's also a written one now. The body outline marketing, which is a body map given to the patient, and he outlines where is his pain and where is it referring to. What about single dimensional? What are single dimensional scales? These are they are assessment tools as well, but they are used only for one aspect of pain, is to rate the intensity of pain. And I think we all, anesthetists or pain therapists, know about these scales. The first is the visual analog scale, which is visual, of course, the numeric rating scale, verbal or visual, and the verbal descriptive scale, which is verbal or visual as well. And the facial pain scales. I think we've had this explained in one of the lectures earlier this morning. But remember that the brief pain inventory is a very essential scale to use. These are quick, I'm going to just point them quickly. That's the visual analog scale, which the patient usually points to where the pain is. You have here no pain, and this is the most distressing, agonizing, unbearable pain. And ask the patient, tell him, where do you think your pain lies? It's from 1 to 10. Of course, our patients, we should translate this in Arabic for them. That's the numeric, where is it? That's a numeric rating scale. It's the scale as well. 0, no pain, whereas 10 is the worst type of pain. That's the verbal rating scale. I think this is mostly used by us, with no pain, mild pain, and the worst possible pain. This is not a sensitive scale, actually. And that's the smiling face scales. This was first introduced for children, and they can use it from the age of 3, but you can use it in adults as well. And here you're combining both the numerical with the facial pain scale. Remember that when you're assessing patients, remember that there are certain patients with barriers to communication, and that can affect your assessment. These, for example, if you have children, if you have individuals who are advanced of age, over the 85 years old, patients with emotional or cognitive dysfunction, patients who are seriously ill, and patients who have a language problem. So in order to overcome that, of course, for the language, you can use an interpreter. Give sufficient time for the assessment in elderly patients. Give the patient the opportunity to use a scale that he can use. You don't have to stick to one scale. Give him an easier scale, pain scale to use. The indicators of pain, according to their importance, is in this type of group, of course, still the patient's self-report is very important. Look for a pathological condition. There might be a pathological condition, and this would make things easier for you. The pain-related, if you don't have, look at the pain-related behaviors. Look at the face of the patient. If he's in pain, he'll be restless, have annoyed face, that will help. Or use the help of one of the family members or the health taker, okay? Use your physiological measures, the vital signs, measure his blood pressure, his heart rate, this will help. But don't rely on these scales unless there are no suitable alternative exists. You don't have to, these are the second and third steps. So the general approach to use the pain assessment tools is the brief pain inventory, as I said. Remember that with follow-up visits, because it helps, if you have your brief pain inventory, this is obtained on the first visit of your patient. It will help in follow-up visits, and in every time the patient comes, he should fill the brief pain inventory, which I'm going to show it to you after in the following slides. Use special tools, of course, for neuropathic pain, okay? Avoid the use of the single-dimensional scales unless you're measuring the intensity of pain. You have to determine the biological mechanisms of pain, because there are many ways to classify types of pain based on consensus now. And the work groups found it most helpful to classify this guideline by the following 4 types of pain. What are the 4 types of pain? They can be pain can be neuropathic, it can be inflammatory, it can be muscular, or it can be mechanical or compressive. And these are the biological mechanisms of all types of pain. I'm not going to discuss the neuropathic pain. You've had a lot of neuropathic pain in one day. But remember also that fibromyalgia syndrome is characteristic by widespread musculoskeletal aching, stiffness, and tenderness, and it might have a neuropathic pain as well, because we said pain might be mixed. Muscular pain is very common. It's a common cause of pain, and failure to properly diagnose it actually may result in poor treatment outcome and delayed recovery and unnecessary surgery. It's very common, very widespread, but poorly assessed. Inflammatory pain, of course, inflammatory pain such as arthritis, whether orthoarthritis, rheumatoid arthritis, as well as infections. Remember, post-operative pain is one of the causes of chronic pain. So look for clinical features, of course, of inflammation, such as heat, redness, and swelling. Mechanical and compressive pain they are usually aggravated by activity, and they are relieved by rest. Neck and back pain are commonly related to muscle and ligament strains or sprains, degeneration of discs or facets, or osteoporosis with compression fracture. Now we come. Is this pain is the pain we've got the chronic or not? Remember that before deciding that, we have to look at other assessments indicated as well. We had an earlier lecture about the role of psychiatry in chronic pain, and this is very important because psychological assessment, you should determine if there are possible psychiatric contribution to your clinical chronic pain in that special patient. So these are the questions you should ask your patient. Is he depressed or anxious? Is he under any psychiatric care? Is he having any history of drug abuse? Has he got a history of verbal, physical, or sexual abuse? This is important to ask the patients. Why? Because psychological assessment is very important, and unmanaged disorders may interfere with the patient's ability to participate in a collaborative plan of his care, and this will diminish the treatment, the effectiveness of your treatment. This is very important now. And of course, increase the suicide risk, which you've seen if you've attended the lecture on the psychiatry in pain, in chronic pain. What about work and disability issues? It's very important. You can't treat a pain. Usually a patient with chronic pain likes to sit and claim for disability and doesn't go to work. So ask your patient, are you working? Yes. Where are you working? If no, why not? Why he's not working? Why? Because chronic pain, the physical impairments that he's got from the chronic pain does not imply that the individual cannot work, because staying at home and not working will increase the psychological and make it unable to progress with his treatment. So the algorithms and guidelines to chronic pain. These are actually the points, the assessment. The patient has pain. Yes, he has. Critical first pain assessment, history and physical. Ask your key questions. Have the pain and functional assessment tools we spoke about, determining the biological mechanism of pain. But remember that pain types and contributing factors are not mutually exclusive, and more than one type of pain can exist. Don't forget that. So is the pain chronic? If the pain is chronic, okay, we'll see. If it's not chronic, it's out of the scope it's out of our scope. But if it's chronic, you should look, is there a specialty correctable cause of pain? If yes, then you have to transfer your patient to a specialty involvement, or a patient or a doctor who's special in whatever specialty that can be corrected. If no, you go to your further other assessments, which are work and disability issues, psychological and spiritual assessment, the spiritual assessment which was pointed out earlier in the psychiatry lecture, and any contributing factors or barriers. If all that is true, we proceed to the management algorithm. These other common barriers, they do exist in patients, where they can be behavioral, such as the passive patient or the patient with low motivation, or he has high expectations. It can be a social problem like a language barrier, a cultural barrier, a lack of social support, fears, financial, or an insurance system problem. Now, what's the brief? I don't know if you know, I think the anesthetist and the pain doctors there should be familiar with the brief pain inventory. Actually, when the patient comes to you, he's asked to fill this. He has to fill this. He fills the pain by putting date, his name and time, and the questions that are in front of him. Usually, the patient can fill this in from 5 to 10 minutes. You ask him first, during your life, have you had pain more than the ordinary pain you might face in your life? And he circles whether it's yes or no. You give him a chart and they said, on the diagram, shade the areas where you feel pain the most. You put an X on it. Rate the pain, circling the one number that describes your pain at its worst. And you give him a scale from 0 to 10. And he circles that. Rate the pain, your pain, at when it's least in the last 24 hours. Rate your pain when it's average in the last 24 hours. Please rate your pain by circling the circle that tells you how much pain you have right now. And write down all the treatments you had or medications, and ask him in the last 24 hours, how much relief pain treatments or medications provided by and put a percent whether it has no relief at all or a complete relief. Then you ask him to circle the one number that describes how during the past 24 hours pain has been interfered with. Number 1, his activity, okay? Number 2, his mood, his walking ability, his normal work, whether he's working outside or housework, if it's a housewife, relations with other people, sleep, and enjoyment of life. He should fill all that. Now, recently it was suggested that pain relief is not the primary goal in chronic pain. There is a distinction which we all need to know between a statistically significant change and a clinically meaningful change. The proposed framework, which was introduced by the Initiative on Methods and Measurement and Pain Assessment Clinical Trials, IMPACT, is very important. They mentioned that 10 to 20% change is a minimal benefit. 30% change is a moderate improvement, whereas 50% change is a substantial important benefit. So the patient should not expect or should know he won't be 100% cured of his pain. And the patient, this is very important, should be followed up for at least 12 months at agreed interval to assess the maintenance of treatment effects. That's the initiative, that's the IMPACT. They recommended 6 cores. First, the pain, the physical functioning, the emotional functioning, the patient's rating of improvement and satisfaction with the treatment. And this is very important, and a consensus was laid earlier this year for that, actually. 5. Okay. Other symptoms and adverse events during treatment and the patient's disposition and characteristics. IMPACT should be practical enough to be easily used in all patients and comprehensive to be useful in evaluation of patients referred to a pain clinic. The guidance on provision of anesthesia service for chronic pain management in 2014, that was in the UK. 1 in every 5 or 7 patients in the UK population has chronic pain. 1 in 7, that was in 2008. Now it's 1 in 5 are suffering from chronic pain. And they are following guidelines and following everything. But chronic pain now is becoming more significant. Why? Because we have more aging, we are living longer, and more cancer survivors and trauma survivors. So, and the and they wondered because the unrelieved chronic pain was a very high socioeconomic burden. And they thought that best practice was the research evidence, actually, to have a multidisciplinary team. This included the staff needed to do that is the pain therapist or the which usually an anesthetist with interest in treating pain. He should have with him a psychologist, a physiotherapist, and a medically qualified person, and occupational therapists and nurses, of course. And they mentioned the Faculty of Pain Medicine in England, which was there's a Faculty of Pain actually since 207. And they fully support the use of evidence-based practice. I will skip that. So managing chronic pain, there's also recently a new guideline. SIGN is the Scottish Guidance Network, a multi-professional organization, and they reviewed the guidelines for assessment, self-management, pharmacological therapies, psychological-based interventions, physical therapies, and complementary therapies. And these are the consensus pathways that were introduced. They were three. The first was for chronic pain assessment, early management, and care planning in non-specialist settings. The second was pathways for pains with neuropathic pain, pathway for using strong opioids in patients with chronic pain, and pathway for chronic widespread chronic pain, including fibromyalgia. This is just a summary of your assessment to the patient with chronic pain. That was our sheets at the Medical Research Institute. We actually translated them in Arabic so that the patients can understand them. The conclusion is comprehensive assessment. You should have a personalized step approach, organizing your information according to the perspectives of your patient, standardize your approach and metrics, use each pertinent perspective. It will help in successful management. And these are the final key points that we should all know. Patients have a right to pain management. Pain must be assessed at regular intervals. Pain should be reassessed soon following an intervention to treat the pain to ensure a response. Institutions are required to have their own policies and procedure for pain assessment and treatment. Educate your patient. This is very important. Educate your patient for pain management is mandatory. Your staff should be educated, whether doctors or nurses who are going to use pain management, they should be educated. Pain assessments are required as a discharge criteria. This is very important. And lastly, the progress in our patient safety will be made not by doing new things, but actually by doing better the things we already know. Thank you.